myself, Dr. Saiprasad Kavathekar, Professor, Department of Pediatrics, D.Y. Patil Medical College, going to talk on Kawasaki disease in children. So this Kawasaki disease is a medium vessel vasculitis. It is a necrotizing vasculitis and it has more predilection with coronary arteries, which are the medium sized arteries. It is an acute disease and self-limited febrile illness. It predominantly affects the infants and children aged less than 5 years, but even adolescent and adults can also have the Kawasaki disease. It is the commonest cause for the acquired heart disease in children. Diagnosis rests on the recognition of temporal sequence of characteristic constellation of clinical findings and the exclusion of other clinical similar entities with known causes. So the diagnosis is mainly a clinical diagnosis and it doesn't rest on the laboratory diagnosis. So it's a clinical condition. The cause of Kawasaki disease is still unknown. The incidence of Kawasaki disease is still rising in India. Initially, Dr. Tobisaki Kawasaki, who diagnosed the first case of Kawasaki disease in 1967 in Japan. The probable trigger are the environmental and infectious agents, which can be a viral or bacterial. Even it has a genetic predisposition. The gene ITPK is susceptible for the Kawasaki disease, and the more severe forms of Kawasaki disease, that is the coronary artery involvement. The pathology includes, it is the medium vessel vasculitis along with coronary arteries. It can involve the popliteal and brachial arteries. So it is a three-phase arteriopathy. In the first, it is the necrotizing neutrophilic predominance. Here the saccular aneurysms can form. In the subacute or chronic vasculitis, it is the main predominance of lymphocyte or plasma cells. Here the fusiform aniforms form, and last is the remodeling phase where the myofibroblasts occur, where the coronary dilatation thrombosis can happen. The diagnosis is by the American Heart Association criteria, which includes fever for at least 5 days and illness not explained by other known causes. The principal clinical features, at least 4 features has to be present out of 5. The first one is the erythema or cracking of lips, strawberry tongue, erythema of the oral and pharyngeal mucosa. So it is a mucosal involvement. The second, it is a conjunctival congestion, usually in the bulbar without exudate. So it is a non-purulent conjunctivitis. Third, it is the rash. Usually the rash is a maculopapular diffuse erythema or erythema multiforme. So usually it doesn't present with vesicular rash. Third is the edema of the hands, feet or edema. Sometimes in the subacute phase it can present with periangal desquamation. And last is the cervical adenopathy, which is unilateral, more than 1.5 centimeter and non-tender also. So these are some pictures where you will see the erythema and edema of the dorsum of the hand. Here you can see the bulbar congestion. Usually the limbal sparing is there and it is a non-purulent one. Here it is a typical strawberry tongue, which you can see in a Kawasaki disease, and this is in the subacute phase. That is a typical periangal desquamation, which is the hallmark of the Kawasaki disease. There are some exceptions to the above diagnosis. If the criteria are less than 4 out of 5 and there is a coronary artery involvement, still we can diagnose the Kawasaki disease. There are other 2 conditions, that is incomplete Kawasaki disease. Here all the clinical features may not be present at one particular point, as the disease condition is a progressive one. So we might get less than 5 clinical presentations in incomplete Kawasaki disease. And atypical Kawasaki disease, it can present with renal manifestation, pulmonary manifestation and sometimes GI manifestations also. Other common clinical manifestations, it can present with septic meningitis. Child will have excessive irritability. There will be some arthritis, some urethritis. It can present with gastroenteritis, abdominal pain, vomiting, and diarrhea. And the peculiarity again is the BCG reactivation. So at the BCG side, there will be presence of erythema. It can present with perianal and periangal desquamation. So perianal desquamation, it can present even in acute phase. This periangal desquamation that presents in the subacute phase, and calculus cholecystitis or gallbladder hydrops and jaundice. There are few complications in the form of, mostly in the form of cardiac involvement. So the classical presentation is with the myocarditis, ultimately leading into heart failure. Some children presents with macrophage activation syndrome. Some children can present with a shock, so that we classically call it as a KD shock syndrome. Usually all this KD shock syndrome presented during the corona pandemic. And the very well-known entity is the coronary artery disease in the form of dilatation of the coronary arteries and the aneurysm formations. So this Kawasaki disease go into 3 phases. First is the acute febrile phase, that is the first 10 to 14 days. So it includes all the classical features of Kawasaki disease along with fever. In the subacute phase, that is the next 2 to 4 weeks, from 14 days to 1 month, the child will have periangal desquamation. The child will have a very severe thrombocytosis. Usually the platelet count would be more than 10 lakhs, and the development of coronary artery aneurysms. So in this phase, there is the highest risk of the sudden death. And in the convalescent phase, so that is months to year, so all the clinical signs which will be disappeared, the ESR will come, CRP will come to normal, and the affected vessels will undergo the remodeling. And then what are the risk factors? Usually the risk factor is the male sex, the infant less than 1 year or more than 9 years of age, the prolonged fever, thrombocytopenia, and hyponatremia. Which investigations we will proceed with Kawasaki disease? So in complete blood count, there will be anemia, which would be normocytic, normochromic. Then there will be neutrophilic leukocytosis. Some patient might present with thrombocytopenia, and it is a marker of macrophage activation syndrome and risk factor for the development of coronary artery aneurysm. The inflammatory markers like ESR and CRP, they will be sky high. Again, there will be serum transaminase like SGOT and SGPT will be raised in 50% of cases. Some patients will have hypoalbuminemia and hyponatremia. There will be sterile pyuria, so more than 10 pulses per high power field and with culture negative, so we call it as a sterile pyuria. The specific investigation, that is the N-terminal pro-BNP, so NT-pro-BNP will be high, so that is 225, can assist for the diagnosis of Kawasaki disease. If there is a myocarditis, there will be changes in the electrocardiogram. Gallbladder hydrops can be detected on the ultrasound abdomen. If child is suspected for a mass, we can send for serum ferritin. Again, the serum ferritin will be sky high, and the ESR will be very much less if it is a mass. So mass can be diagnosed with high serum ferritin and low ESR. Then we need to go with serial echocardiography even in diagnosed Kawasaki disease also, and for the diagnosis. How this echocardiography help? So echocardiography is needed for the diagnosis, then risk stratification, treatment planning, and prognostication, also for the follow-up. So echo must always be performed at diagnosis. And what we are going to see, so we need to see the main coronaries, so we need to see left main coronary artery, also need to see its branches, LAD and circumflex. We need to see for right coronary artery, and we need to see the coronary artery by the Z-score classification, and which includes either no involvement or a dilatation, or small coronary arteries, moderate size coronary artery aneurysms, and large or giant coronary arteries. So if the Z-score is less than 2, then the coronaries are not involved. If the Z score is 2 to less than 2.5 millimeter, then it indicates there is some dilatation. If it is 2.5 to less than 5 millimeter, it indicates there are small coronary artery aneurysms. If it is in between 5 to 10 millimeters, then it indicates the moderate sized coronary artery aneurysms, and if it is more than 10, it indicates the giant coronary artery aneurysms. So we need to check for internal diameter of the coronaries. So we need to perform even in uncomplicated patients at 1 to 2 weeks, and also 4 to 6 weeks even after treatment. So echocardiography is a must to diagnose and for risk stratification and for treatment planning also in Kawasaki disease. So these are few photographs where in one shape, so there are giant coronary artery aneurysms in left anterior descending and right main coronary artery. So in right coronary artery you can see the multiple aneurysms in the right coronary artery. So there are many differential diagnoses for the Kawasaki disease, which includes viral, either measles virus, enterovirus, or Epstein-Barr virus, adenovirus. For bacterial, we need to differentiate it from scarlet fever. Scarlet fever we can easily rule out because apart from Kawasaki disease, where in scarlet you can get strawberry tongue, but the lips are not involved as seen in Kawasaki disease, and usually the fever gets response with antibiotic very fast in scarlet fever. As against Kawasaki disease, we don't have any response to the antibiotic. Other drug reactions or toxic shock syndrome we need to differentiate from the Kawasaki disease. And coming to the treatment, the gold standard treatment in the Kawasaki disease is intravenous immunoglobulin, so that is the IVIG, and we should start preferably within the first 10 days of onset of fever. So if we start before 10 days of fever, the chances of coronary artery aneurysm development are very less, and the dose is 2 gram per kg of IVIG. If we didn't diagnose the Kawasaki disease in first 10 days, still we need to give the intravenous immunoglobulin to that patient. Along with intravenous immunoglobulin, we need to start the high dose of aspirin, that is 30 to 50 milligram per kg per day. So that is the anti-inflammatory till the child becomes febrile, and then we can start the dose of aspirin with 3 to 5 milligram per kg, that is the antiplatelet dose. So that is the algorithm. So once we diagnose the Kawasaki disease, we start with immunoglobulin 2 gram per kg along with aspirin 30 to 50 mg per kg per day until the child becomes febrile. But there are certain risk factors or primary intensification of therapy if there are few high risk factors. And which are these high risk factors? First is if the infancy group. Second, Kawasaki disease presented with KD shock syndrome or macrophage activation syndrome, or there are early presentation of coronary artery abnormalities. In that case, along with intravenous immunoglobulin, we need to start with either oral prednisone 2 milligram per kg until the child becomes febrile and CRP normalize, and then taper the oral prednisone over the next 2 to 4 weeks. Or we can start with methylprednisone in the dose of 10 to 30 milligram per kg for 1 to 3 days, followed by oral prednisone, and then again taper for next 2 to 4 weeks. Some centers also give infliximab 5 milligram per kg as a single infusion dose over 2 hours. So all this, either of three, so any one, either oral prednisone or injection methylprednisone or infliximab, they can be started upfrontly if we suspect the coronary artery abnormalities or macrophage activation syndrome or KD shock syndrome, or the age is less than 6 months. So along with IgIG, we need to upfrontly use either of three molecule, and along with that we need to continue the antiplatelet dose 3 to 5 milligram per kg. Some patients, they can present with IVIG resistant Kawasaki disease, and usually this is seen in 10 to 15% patients. And how to diagnose the IVIG resistant Kawasaki disease? So they are defined as either recurrence or persistent of fever at least 36 hours following the completion of first dose of intravenous IVIG. Then what are the options for the treatment of IVIG resistant Kawasaki disease? So we have the options like we can repeat the second dose of intravenous immunoglobulin, or we can give the corticosteroids or infliximab. Usually the addition of corticosteroid is advised if the child is having myocarditis or if the child is presented with macrophage activation syndrome. Then what are the management of cardiovascular sequelae? The goals for the long-term management are to prevent thrombosis and myocardial ischemia while maintaining cardiovascular health. Drugs used for myocardial protection include alpha blockers, carvedilol, metoprolol or bisoprolol. We can add with ACE inhibitors or ARBs. Statins may be beneficial as an adjunct therapy in Kawasaki disease with coronary artery lesions. We need to put the child on thromboprophylaxis. So this antiplatelet drug like aspirin are commonly used in Kawasaki disease. But if there are some giant aneurysms or large distal aneurysms which we have identified on CCT, then dual antiplatelet treatment with aspirin and clopidogrel is preferred. Anticoagulation with warfarin to achieve a target international INR ratio of 2 to 3 is used. Low molecular weight heparin is equally effective to warfarin, as usually it's very difficult to monitor the INR, and to monitor the dose of warfarin is difficult in children. So this low molecular weight heparin is preferred. And what are the complications? So coronary artery aneurysms, that is the first complication of Kawasaki. So these aneurysms can rupture, there can be a coronary thrombosis, there can be a stenosis also. Some children at younger age may present with myocardial infarction leading to sudden death, and usually this happens in the young age or in the adolescent to early adulthood group. Sometimes we can't identify the Kawasaki disease in the childhood, or we miss the Kawasaki disease in the childhood, and later on they presented with acute myocardial infarction and sudden death, usually in the adolescent or early adult group. Then what is the long-term management? It includes risk stratification of coronary artery abnormalities based on echocardiographic coronary artery luminal dimensions on the Z scores. We need to go for frequent cardiology assessment and surveillance. Then we need to advise for lifestyle, then psychosocial issue we need to take care, and we need to advise for follow-up. What is the prognosis for Kawasaki disease? Usually the time treatment reduces the risk for coronary artery aneurysms to less than 5%. So if we identify or diagnose Kawasaki disease within the first 10 days, and we introduce or we have given the intravenous immunoglobulins at that time, the chances of coronary artery aneurysm development is less than 5%. Some children present with recurrent Kawasaki disease, and that number is very less, usually 1 to 3%, and the treatment remains again the same. It is we need to again treat it with intravenous immunoglobulin. 50% of coronary artery aneurysms regress to normal lumen diameter by 1 to 2 years after the illness. So these regressed aneurysms are associated with marked myointimal thickening and abnormal functioning of vessel walls. Smaller aneurysms being more likely to regress. Giant aneurysms are less likely to regress to normal lumen diameter, and which can lead to thrombosis and coronary stenosis. So these giant aneurysms are more prone for cardiovascular complications. Some children, they may require coronary artery bypass graft if the myocardial perfusion is significantly affected, and here we need to use the arterial graft and we should not use the venous graft, and very rarely the child may need the heart transplantation. Once we have treated with intravenous immunoglobulin for the Kawasaki disease, so what vaccine we need to advise for that child? So patients undergoing long-term aspirin therapy, they should receive annual influenza or flu vaccine to reduce the chances of Rett syndrome. Second, we should not advise the live vaccine, especially this measles, mumps, rubella and varicella vaccine, or we should defer it till 11 months after IVIG administration, as this intravenous immunoglobulin interfere with the immune response to live virus vaccine as a result of specific antibody response. And we should continue, or we should advise non-live vaccines or killed vaccine as per the scheduled dates. So we should advise the influenza vaccine to all children, and the live vaccine should be deferred till 11 months of age. And these are few references of Kawasaki disease from where I have prepared my lecture. Thank you very much.